Okay, I come back together again, and I will share. Let me get this cat out of the way. A presentation on other organ systems that we're not going to spend a whole hour on each, since they are pretty rare. In the same format, I'll present, and then we'll have time for questions and answers. And this is really a time we can have pretty much any questions, and we'll attempt answers. And any of our speakers who are still around could potentially jump in if there's more broad-ranging questions. I'm pretty good at fielding most questions after 25 years of listening to the experts give the answers. But if there's things that we definitely want to get a second opinion or a third opinion on, we can do that as well. So I'm going to share my screen and just calling this other signs and symptoms of PXE. I have here, with thanks to Lionel Berkovich. Lionel's at our meetings every time. He's the person who diagnosed my kids, and as he says, his whole life changed as a result of that diagnosis, because he then wound up being very involved in PXE for the rest of his life for the last 25 years. And Lionel usually gives several of these talks, but he had a conflict with one of the academies of dermatology. I think it might have been the New England one, but I'm not sure which, planned at the same time. Okay, so this is beyond skin and eyes. So far we've heard skin and eyes and genetics, actually, and I'm also leaving out the genetics because we just heard good talks on all of those things. Everybody with PXE, almost without a single exception, has some skin involvement, and if it's sometimes very obvious and sometimes not so obvious, most of the time obviously. And everybody, I've not seen a single person with PXE without eye involvement, because that's part of the definition of the disease. And eye involvement could be as minimal as Wayne showed us, as peau d'orange, which is one of those first signs of PXE, all the way out to bleeding. Those are the cardinal, the most common, the most obvious signs, and eye involvement is probably the most difficult sign, although skin certainly can be difficult as well. So I'm going to talk a little bit about things we know less about, because we have fewer people with these manifestations. And we also can't always parse out whether or not a person has any of, for example, cardiovascular issues because they have PXE or because they have a family history of cardiovascular issues. So probably most of you could go to your local store or get on a train or bus, at least before we were all in isolation, and ask, does anyone have cardiovascular disease? And lots of people would say they did. So to parse out whether or not you're experiencing cardiovascular disease because of PXE, or it's worse because of PXE, or it's not because of PXE, is really hard. And again, I'm going to make a pitch for our registry system, our surveys, our gathering medical records. It's the only way we're going to learn if we could get all the pieces of the puzzle. So the things I'll talk about are peripheral vascular disease, coronary artery disease, hypertension, and cerebrovascular disease. So peripheral vascular disease is something that I think might be almost as common as eye and skin in PXE. I think almost everybody has some calcification of the elastic fibers of the mid-sized arteries. You've heard about that from others. There's a thickening of the innermost layers. My team, could you just mute everybody? Sorry, I forgot to do that before we started. And sometimes a stenosis, a narrowing of involved vessels with similar changes to those observed in arterial sclerosis. So again, it's similar to other kinds of disease, but we find so many people with PXE who do have this PAD, peripheral vascular disease, peripheral arterial disease, that it probably is related to PXE. This is the feeling of cramping in your legs with exercise. So it is not the feeling of cramping in your legs in bed. That's a different thing, probably not related to PXE, maybe related to electrolytes or another syndrome called restless leg syndrome. But this cramping in your legs that starts after a few minutes of brisk walking or climbing the stairs, that's probably due to this peripheral artery disease called intermittent claudication. Again, it's a common condition, relatively common, and so it's possible it's not because of PXE, but it's probable that it is. And then sometimes coolness, numbness, tingling in your feet may also affect your arms. So, for example, we've talked to hairdressers who have to have their arms up in the air a lot, and they feel it in their arms. And then diminished peripheral pulses is common. There's been several jokes about people saying they should wear some kind of bracelet that says, even though you can't feel my pulse, I'm not dead, so please don't bury me, if they passed out. So the diminished peripheral pulse is pretty common. The management of this is a lot like everything else with cardiovascular disease, and also even things that Wayne and Olivier talked about, I think Yoni to some extent too, that there's certain things that we need to be doing, and actually all of us need to be doing this regardless of whether or not we have PXE. But in any case, a low-fat diet, aggressive control of high cholesterol, stopping smoking. Smoking is one of the worst possible things. In our studies, we showed that people had vision loss some 5, 8, 10 years earlier than others if they smoked. Now, loss is not so common anymore due to the injections, but in any case, it accelerated eye disease. Doppler studies could help determine whether or not there is sufficient blood flow. More invasively, angiography or angioplasty. Some people wind up with vein bypasses. I've listed one drug here that actually I forgot that our good friend John Schonecker, who will be here tomorrow with us, has said this drug Trentol is not really used very much anymore, and then Pletol. So in any case, you wouldn't be prescribing these drugs to yourself. At that point, you would be asking your doctor, your clinician. The best thing in the world for this apparently is walking, and the thing that hurts is walking. So it's a catch-22. What I've been told is that the blood vessels actually find new pathways. They increase their options, so to speak, the more you walk. So walking could be quite good. We've also learned, and I don't know if Kuhn tomorrow will talk about this, but in some studies it shows that exercise increases the amount of pyrophosphate in your blood, which is low in your blood and may be causing the calcification anyway. And so say 20 minutes of exercise a day probably has enormous benefit for you overall. And then moving to cardiac disease and PXE. So coronary artery disease, things like angina, myocardial infarction, very rare reports of this in children and young adults. And those reports really didn't control for potentially other things impacting those kids or those young adults. So there we go. What we find is that again, we can't really parse out whether this is regular coronary artery disease or due to PXE. The management of this is very much like the management for anyone. And that's something that I am continually answering for folks is, should I manage this differently? And the answer is no. We don't know exactly why there would be cardiac disease except for perhaps this mid-laminar layer of the arteries being affected. But we do know that many of the things, most of the things you do for regular cardiac disease, you should be doing. So aggressive management of all the risk factors. Again, high blood pressure, smoking, cholesterol, also called lipids, managing all those. Having a cardiac stress test would probably be a good thing. And then again, angiography, angioplasty or stents, maybe Plavix or other drugs. There's some risks in PXE. I often get asked, should I take a drug that might have a risk in PXE? And one of the things you have to do are weigh the pros and cons. So if I'm being considered for a blood thinner, for example, to decrease my cardiovascular disease or my stroke risk, I need to weigh do I want to increase perhaps the potential that I'll have a gastrointestinal bleed, or that I'll have some vision loss versus having a stroke or a heart attack? Strokes and heart attacks are often life-threatening. Gastrobleeds can be life-threatening, but they can be more easily managed, and they're usually very limited in their in the event. Cardiac disease for life is not a trivial thing, and so again, you'll be working with your doctor if you get to this point to make a decision about the risks and the benefits, like we have to with most things in life. And then a coronary bypass graft, and again, your physician will know not to use a mid-size artery, because those in fact are usually have some manifestations of PXE. Hypertension in PXE, so the exact incidence is not known. Estimates have ranged in the 10 to 25% range for adults, but that's also very common in the non-PXE adult population, high blood pressure. The mechanism for high blood pressure is renovascular narrowing in some patients. So the narrowing of the artery to the kidney can cause hypertension. And then ultrasound does show vascular calcifications in the kidneys in PXE. Actually, every organ appears to be affected subclinically, meaning that if you took a biopsy, and we have done this actually in individuals for whom we've had autopsies done, a biopsy of every organ has more calcification in it than a person without PXE. However, most of that doesn't cause signs and symptoms in the sense of having some kind of clinical repercussion for you. So regardless of the mechanism, again, it doesn't matter whether you have hypertension because of a family history or some other, obesity or smoking, whatever your thing is, controlling the hypertension is important because high blood pressure is an important risk factor in coronary artery disease, stroke, and peripheral vascular disease. And in all these cases, as I say these things, we don't have evidence in PXE. We haven't done any large studies. I mean, you heard Eric say there haven't even been large studies in plastic surgery in PXE, and there's plenty of people having plastic surgery. Again, capturing people's information and data has been difficult until now. And so we've done a reasonably good job of doing that, but we want to do more of that so that we can actually get these questions answered. In fact, during the break, I had a back and forth email with Eric, and we're already gearing up a study on plastic surgery and PXE, which will be great. Okay, moving to the gastrointestinal manifestations of PXE. So we do see gastrointestinal bleeding in about 10% or less of people with PXE, and abdominal angina. And so gastrobleeding is one of the most dramatic manifestations because it usually is fairly sudden onset. It seems to occur when people are relatively young and other manifestations have not gotten so bad. In most gastrobleeding, it's gastric, and so you'll see it, what we tell people to look for is black tarry stool. The actual source may be difficult to pinpoint, and the mechanism is unknown, but the arterial pathology, meaning this mid-laminar layer of the arteries being affected, is probably to blame. Again, here's another case where when a person calls us who's been hospitalized or on their way to the hospital, we say, make sure you're getting the same treatment anybody else would get, and do tell the physician that you have PXE. And then cerebrovascular disease, strokes occur with increased frequency in people with PXE under 65. So generally there aren't that many strokes in people in the regular population. And so when we see more in people with PXE, then we know that perhaps this is related to PXE, and we're guessing again, we need to do a study. And most are due to small vessel disease. Small infarcts are most common. Many infarcts can cause dementia, and we haven't necessarily seen an increase in that in PXE. And then if person taking aspirin or Plavix, a blood thinner, therapies can be associated with the increased risk of GI bleeding and maybe with strokes, et cetera. So again, there's a chicken and egg here in the sense that we tell people don't take aspirin, don't take steroidal anti-inflammatories because they could increase your risk of bleeding. And then at the same time, some of those are heart protective or could be stroke protective in the case of a blood thinner. Okay, that's the end of the formal part of the presentation. So I'm going to open this up to questions now. And you can put them in the chat, you can raise your hand, you can unmute yourself. Any correlations between PXE and its associated calcification traits with conditions like bone spurs and abnormal mouth bone growth? So not that we know, John. Our orthopedic friend, John Schoenecker, who's going to be with us tomorrow, that's a good question for him. He's very interested in what is the association between what's happening in PXE, because if we follow the trail, and you saw many kind of cartoons of this, but if it's pyrophosphate is too low in the blood, tomorrow you're going to hear a little bit more about that because it's one of the targets we're going after. Then what implications does that have on the whole system, and certainly in terms of bone and tissue, et cetera, and their relationship to each other. One of our cartoons too is a seesaw of all these minerals. How do you keep these minerals in balance? How do you make sure that you have the right amount of them? And then what impact do they have on other systems like bone and healing? When a tissue is injured, calcium minerals come in and help in the healing. So we don't actually know. We have not seen increased bone spurs in people, but it's a great question and one that we'll definitely get into one of our next questionnaires.
Thank you so much.
Welcome, thank you. And is that a Great Pyrenees with you?
Yes, that is one of my pups. He's a Great Pyrenees. Love him. Tucker.
I have a favorite Great Pyrenees I spend a good deal of time with, and I love them. Yes. There's a great Facebook group for them.
Well, thank you.
Yeah. Jenny asks, are there any info on how alcohol consumption affects symptom manifestations? So not directly, there's no direct, even anecdotal stuff coming out on that. However, of course, what we're all warned of is that excessive alcohol intake and even moderate might not be so good. On the other hand, we do read some studies where we see the Mediterranean diet, et cetera, leads to a longer lifestyle, and that includes wine, for example. So I think in moderation, it's probably fine and not doing anything particular. If we follow the dots, and this pyrophosphate level in the blood is the story or part of the story, then it's really more interesting or concerning to see if we can get the pyrophosphate levels of people with PXE higher, and things like alcohol probably have no effect on that. Things like smoking might, because of the huge amount of effect it has on even oxygenation of cells and the problems with smoke and secondhand smoke and now thirdhand smoke, et cetera. So there's way more impact there. Stefanos asked, what is the average expected lifespan? It's normal. And certainly just like anything else, anywhere else, everybody's going to have a different lifespan for lots and lots of reasons. What we found when my kids were diagnosed, the Merck manual, which was one of those lay Bibles for people to read about medical conditions, said that people with PXE died at age 30. And you can imagine that was terrifying for me as a parent. And we, though, have now documented people in their 90s with PXE in our surveys and our questionnaires, and some of them quite healthy. Again, a lot of other things are going to impact that, just your familial genetics around longevity, certainly exercise, diet, making sure you're in a good environment. While Wayne said probably stress is not related directly to vision loss, certainly stress is related to a lot of things in our life, and how do you take care of getting the support you need in life, being with people who are supportive, living with or near family. All those things indicate that lifespan can be impacted by that. As for the aggressive lipid management, Connie asks, especially for those who do not have clinically high cholesterol, what meds do you recommend for those who cannot tolerate statins? So I'm not going to recommend anything, and I'm going to keep saying that about recommendations for anything specific. Working with your clinician, your doctor, is your best bet. If it's not a high cholesterol, I think they won't want it managed with medication. And I think the first thing to try is diet. And so certainly there's lots of good stuff on the internet from the American Heart Association and some others that allow for good heart healthy diet and what constitutes a good heart healthy diet. So making sure that, you know, your diet's low fat, that it has lots of fruits and vegetables, not so much refined sugars, less and less of refined meats, etc. Maybe less red meat, more toward chicken or other proteins. So those are the things that I think would help. And then exercise, of course. And somebody else followed up with a recommendation. But again, what I will ask everybody to do is not to make recommendations to each other. And I appreciate your sharing your experience. Good job, Josanna. But in general, we're going to refrain from making recommendations. But do consult with your physician about this. And in all cases, I think try managing without the drug at first, and of course, go right to the drug if he or she suggests it. Miriam, your hand is up.
All right, I'm unmuted. So my question to you is about involvement. I know you touched on this a little bit, but with kidneys and the liver, are you at an increased chance of getting a kidney stone? Because I've had one, and I kind of wondered, you know, I know there can be a lot of causes for that, but I wondered if my PXE can contribute to that. And also with the liver, I have elevated liver enzymes that they can't really figure out why, and they finally did a biopsy and found that what they've diagnosed is autoimmune liver hepatitis, so autoimmune hepatitis. Yep. So I know that I have inflammation in my liver, and they can't really figure out why. So I'm wondering, can PXE have any involvement there?
Okay, great. I'll take both those questions. So for the first, yes, we did do a study and some of you participated in it. So thank you. I wish more did, but we got a good handful showing that in fact, kidney stones are found at a much higher rate in people with PXE, much higher than the average population. So kidney stones are definitely a potential liability for people with PXE. Now, not everybody, and we don't know why, a subset. And Olivier showed us some of the different genes that could be involved, and we're going to have other cocktails of genes involved. And so we're going to get different flavors of PXE. The other, autoimmune hepatitis, I happen to know a great deal about. And in fact, it's an inflammatory process not related to PXE. And so if there's an issue with PXE and the liver, it would be increased mineralization. And while we do see more calcium in the tissue of the liver, for example, and the kidney and skin and arteries, in the liver, it seems not to have any impact on the body. I would bet that you have an additional disease like we were talking about in the last session, and that's unfortunate, but it's a separate process.
Okay, thank you.
I also have that. I also have autoimmune liver disease.
Yeah. And I bet if we do a poll of any 100 people, we're going to find 3 or 4. Yeah. Yep.
Yeah.
So there are definitely, you know, if we spend some time now, we can spend the rest of the meeting saying, and who has, who has cancer, who has, you know, gout, and who has, so we have lots of overlap.
Yeah. Okay.
Thank you, Chair.
You're welcome, Miriam. Cheryl, you're up next. Oh, you're muted. Still not hearing you, Cheryl. Wonder if your mic's working. Why don't you can we hear you now? I heard you before. I'm going to go to Ray Wynn while you're trying to figure that out, and then we'll come back to you.
Thanks, Sharon. I recently had cardiovascular tests. I had the ultrasound and had cardiovascular ECG, and said my heart was in really awesome condition. So he didn't do a stress test. I made him aware that I did have PXE. I mean, I was surprised it was so good. They said they wish they had. He said he wished he had my heart, which was great, and a slightly enlarged valve, but that's because of extreme exercise I've done. Should I push to go further, or do I just assume I've got a really good heart?
Yep, just be glad that happened. And yes, so we used to recommend that every 5 years, everybody had a cardiac workup. And now we just say, when you get diagnosed, have a baseline exam. And after that, just look for the signs and symptoms of heart disease, shortness of breath, if you're becoming obese, working on your diet and exercise again, and maybe having a cardiac workup if you gained a lot of weight, stuff that stresses the heart anyway. So that sounds great.
I'll relax then. Thank you very much.
Great. Cheryl, can you speak now? No? Keep working on it, Cheryl. I'm going to go to Susan.
Yes, can you hear me, Sharon?
I can, yes.
Okay, thank you so much. My question is regarding those individuals that experience severe claudication. What kinds of interventions and treatments besides pharmaceutical are being used, and how successful are they?
So you said for claudication, right? It broke up on my end,
yes.
Not your end. Yeah. So, and this is a good question to ask John Schonecker tomorrow. He will tell you that there are some new drugs that are working fairly well. Apparently, a lot of these drugs actually make the blood vessels more elastic so they can fit through tight spaces, but that the very best thing is to just allow new pathways to be developed, and that's through exercise. Mm-hmm. And I realize it's a double bind because the people that I've kind of worked with a bit on this say, but it hurts so much to walk. So it's figuring out what's that way to push yourself to walk more, obviously not in excruciating pain, in order to get past and through the part that is going to be painful.
Thank you.
All right, Cheryl, how about we try you again? Looks like you're changing location, maybe. No sound yet. Feel free to keep trying. I'm going to read some of the questions out of the chat. So, John, you read a paper on the high failure of femoral stents in PXE. Any corresponding research on cardio stents? I haven't seen enough people with reporting cardiac stents either having it done or failure. So I don't have any information on that. I will, though, put it on our list of things to look up. We do not have a good, I shouldn't say good, we don't have a dedicated cardiologist the way you're seeing all these other experts come through, or gastroenterologists, because the cardiovascular and gastro manifestations are not as common. So you're going to see more of our ophthalmologists and dermatologists and geneticists and now orthopedists. And we are cultivating some relationships with cardiologists. In fact, during the break, I was discussing another case with one of them. And then Deirdre, what about calcium scores? So I think when you do get a workup and discuss it with your clinician physician, it's always good to have all of these things brought into the picture so that they get the full puzzle. That they will definitely opine on those for you. This whole thing with calcium is a little tricky, and we knew that maybe, well, certainly when my kids were diagnosed 25 years ago, 30 years ago, the recommendation was to reduce calcium to prevent calcium from being laid down in the arteries, the eyes, the skin, etc. And it turns out there's calcium and magnesium, probably some phosphorus. There's other minerals as well, so it isn't just one. And the other issue here is that the the human body is quite amazing. There's been studies done, and they weren't intentionally done. But for example, malnourished mothers who are breastfeeding leached calcium from their own bones to make sure that the calcium level of the milk being given to the child was high enough. The body does this balancing act, this regulation of its own self of plasma, the calcium in the blood, calcium in the bones, calcium in the tissue. And so once we learned that, oh, this gene ABCC6 is actually regulating ATP and pyrophosphate and these other things. And those are sort of the downstream effects that are causing these more obvious manifestations to all of us, that reducing calcium in the diet wasn't going to do anything about that regulatory system in the body. And so while calcium scores are definitely going to be important to your cardiologist, I think talking to him or her about that makes a lot of sense in the context of your cardiovascular health. And for PXE, they don't seem to be a good indicator. One of the things we're going to talk about tomorrow, and I'll certainly make a mention of today, is to do a study on PXE for a drug, which we are getting to. I mean, some of you have probably already sat there and thought, then why are we not all taking pyrophosphate and increasing the pyrophosphate level in our blood? Because if we did, then we would have less mineralization, less calcification in these peripheral tissues like eye and skin. And the answer to that is, that's a great question. We do want to test that. But if we test it, one of the things that we need to be able to do is to know, are we on the right track? So what's the measure of that? So in other words, when we did the magnesium study, when this other bisphosphonate study that you're going to hear about tomorrow was done, what do you measure to show that that thing is working? So if I say I'm going to feed half this group magnesium and half this group pyrophosphate, do you come back in a year and I measure how the lesions in your neck are? Do I measure the angioid streaks in your eyes or your eye bleeds? And this is some of the work that Wayne did with Mark Lebwell in New York. And the answer is yes, those are fine things to measure. But for example, if I take a biopsy of your skin today, I can't take a biopsy of that exact skin in a year from now because I already took that skin. And skin is variable, one place to another, even millimeters away from each other. And then the eyes, there are some studies that show the length of the angioid streak might be a good marker. Increased bleeds or these areas of more fluid might be useful. Some of that landscape stuff that Wayne showed you, like computerized axial tomography. But the problem is, and you all know this from living with PXE, is it might accelerate in 1 year and then be quiet for 5 years. And what if you're taking the drug during the quiet 5 years? It'll look like the drug made it quiet when it didn't. What if it accelerated and it was going to accelerate anyway, and the drug actually had it accelerate less? You won't know. So I joke and say, well, you have to do a 20-year clinical trial, which no drug company will do. That's crazy. And so we're trying to find ways to measure PXE and to measure its progression. And so some of what we're doing is asking you all for a lot of information, because as we look at all your medical records, look at your own experience, we can start to say that one thing or another might be a better measure overall. Okay, in the chat, autoimmune hepatitis reportedly has a prevalence of 2 to 17 per 100,000. Yeah, you know, Debbie, I know that, and my husband had autoimmune hepatitis the last couple years, and so we did look at a record of a person with PXE with his doctor at Johns Hopkins. He had the best team in the world during a liver transplant, and didn't find that there was the irritation from the calcium deposits causing the inflammation. But, you know, again, I think probably the jury's out, and we can associate almost everything with this until we have the evidence. So yes, we probably should collect enough autoimmune hepatitis, although I think I asked about 3 years ago and we came up with 3 cases in 1,000 PXEers, which could be higher than the average population, but might not be. I may have just had a sampling bias there. Okay. Debbie Noble has a question.
It's a really difficult one. Hello. It's a $63 million question. And would you consider that somebody with PXE has a greater risk of contracting coronavirus or not?
Great, good question. As you know, we don't know a lot about coronavirus yet. We do know about a lot of other viruses, and we know, I should say we don't know anything about novel coronavirus. We do know about other coronaviruses. And we don't think that there's a supportive immune system in PXE. However, we're also learning that there are some really interesting, I shouldn't say interesting, but unique aspects to this coronavirus, and long COVID, for example, is impacting various organs later on, after months after you've had COVID. I would say your risk is the same as anybody else's, which seems to be highly variable, because as you know, some people can hang around it and get asymptomatic expression or non-expression, and others get sick very quickly and very severely. So I would say protect yourself just like anything else. Hand washing, in the case of coronavirus, mask wearing, those things that seem to be helping overall. Thanks, Debbie. And I see Dina and Susan, but I'm going to go to the question that was put in the chat a little while ago. Can calcification of the placenta be caused by PXE? That we know absolutely, because we studied, I forgot how many placentas, quite a number of years ago. Tamara or Matthew can look up the date of the paper, but I think it's the early, maybe 2010 or something, 2014. We studied, I forgot how many pregnancies, 520 pregnancies with controls. That was a really robust study for us. And yes, the placenta of women who have PXE is calcified. And then we studied the outcome for their babies, and the outcome was exactly the same as women who didn't have a calcified placenta. So we do know that the placenta, again, another organ, if we look at it microscopically, if we do biopsies of it, we're going to find calcification. Sometimes it alarms the OB when the baby's being born to see that placenta. And so we do actually have a bulletin on this. We have a fact sheet on it that we can give to you to take to your OB or your midwife or whoever's delivering, so that they know, yes, likely this placenta is going to look calcified. There is no ramification for the baby, and there's no ramification for the mother. We've also studied those 520 pregnancies. We studied 795 pregnancies in 306 women, the largest study to date. We have another study too of 500 women. Maybe that was just the placental one, but anyway, hundreds of women, lots of pregnancies, and the women themselves gave birth multiple times to healthy babies and didn't have any manifestation themselves. The one, or problem themselves, the one issue is if a woman is told by her ophthalmologist that she's in a period of active bleeding in her eye, so she's in one of these aggressive times, that Valsalva maneuver that Wayne talked about could be a part of delivery, that bearing down, that kind of pressure. And so in that case, some obstetricians and women might decide together to opt for a C-section. We don't just say go for a C-section. In fact, there's an entire campaign against so many elective C-sections now, that lots of things are not imparted to the baby if the baby's not vaginally born, and there's more risk for the mother since it's surgery. So in general, pregnancy is completely fine and normal. Okay, Dina, you are next.
First, I just, you cut out for one word at the beginning of the COVID part where you were talking about whether we're immune suppressed or not. Yes or no? No, right? No.
No.
And by the way, I had COVID and here I am. So just
wow, great, yes.
I just wanted to ask you, and I know I'm sensitive on this issue, but I think you said, and I don't want to misquote you, that because of the treatments, the injections, that loss of vision is not so much an issue anymore. So I was wondering if studies had been done, and also I just want to say possibly it just postpones it into the future, and maybe some people die first. I don't know if you had a study, but So if you could answer.
Yeah, so we haven't had a study. I'm trying to do one, and we didn't get many people to give us their eye records. So we're relaunching all our studies on this new platform that I hope is easier. And the new platform in the US, you'll be able to just connect your electronic health record. If you have 20 of them, you can connect them all, and then all those health records are in one place, and we can easily do this research. In the past, you remember, we had you trot to your doctor, get him to copy it. He or she had to send it to you, and then you had to send it to us. So the answer to this is the jury's out. But my experience is so different over these last 10 years or so. And that is that when I founded PXE International for those first 15 of these 25 years, every single day I got a phone call or an email from someone saying, I've lost my vision. What do I do? And now I get 2 or 3 a year of those kinds of calls. And so you might be right that we're just pushing it way out there. And I don't know if Wayne is still in earshot, but at least so far, we are seeing much less vision loss. And the interesting thing, Dina, that I'm finding is we're winding up with 2 different support groups, really. And one is people who did not have the advantage of the anti-angiogenesis drugs, and they are people who have vision loss, lots of you, in fact. And guess who's not on this webinar? It's all the people, let's say 40 years, 50 years old and younger, who don't have vision loss and aren't interested in hanging around with us and learning about PXE because they don't seem to have anything except very bad skin or moderate skin problems. So again, that's completely anecdotal. And here's Wayne to tell us what he knows about what's happened over the last 10, 20 years.
Well, what you're saying is absolutely correct. I spent a lot of time, there's a lot of time we spend seeing patients. We used to see someone and we were unable to treat them, and we would spend time with them. It was a hand-holding session, and we'd say, I'm sorry, we can't treat you. See me in a year and call me if the other eye gets blurry. But now we say, we have a great treatment for you, and you're going to see me once a month, and hopefully you'll be in the 90%, not 100%, when we stabilize your vision. And I agree, there's much less vision loss. Fewer patients are losing vision, thank God, to pharmacology.
So, I mean, you did talk about the frequency of the injections, but are you, once you get started with them, are you doing it prophylactically? I mean, like every month, is it on a regular basis normally or not?
Well, we talked a little bit about it. There are different strategies. So nobody gets shots prophylactically. That is, if they have never had leakage or bleeding. If they've had leakage and bleeding, they do have choroidal neovascularization. We have to stabilize them, and we would see them, give them an injection, check them in the first week or so. After that, they would come in monthly. If they're still leaking and or bleeding, they would have an injection. Some physicians treat 3 injections in a row before they would withhold. Most of us like to stretch out the treatment. We would like to withhold whenever possible without withholding recklessly. So we set the bar low for injecting. And so if there's new leakage, persistent leakage, new symptoms, new hemorrhage, we would offer an injection, but we like to treat on an as-needed basis or extend the period between shots. So it's never more frequently than monthly because the medicine is in the eye for at least a month, with rare exception. And I've had patients that had 40 injections in a row and didn't need one for 6 years, so it varies tremendously.
Oh, Dina, you're muted.
Have you ever had any problems with the injections, you know, bad effects, infections?
So I've had, I don't know how many injections I've given in, 14,000 probably in the last few years. Not to PXE patients, mostly macular degeneration patients. vein occlusion patients, diabetic patients, and I've had 3 infections. They've all fortunately been treated with antibiotics, and they've all needed injections afterwards and had them. It doesn't always turn out that way. You could get a bad infection and actually lose the vision in the eye. So that's one of the dreaded complications. So we do everything we can to prevent that. We put betadine in the eye, which brings up the next problem, which is a lot of patients complain of irritation after an injection. So we try to wash out the betadine afterwards. That can be an irritant, but it's worthwhile to prevent infection. Other complications, retinal detachment. We are putting a needle in the eye. We're injecting some fluid. There's some fluid dynamics. The vitreous jelly is moving around when we do that. And I've had 3 patients who've had detached retinas over, again, 14,000 injections, and they've all been repaired. So, I mean, retinal detachments occurred before injections. We're not sure they're all related to the injection. They didn't happen immediately afterwards. One patient had multiple tears before we ever injected her, so probably 2 possibly related to the injection. There was a theoretical concern about these are anti-VEGF drugs, anti-vascular endothelial growth factor drugs. And could they cause systemic side effects? That is, patients who are at risk for heart attacks and strokes, some of our seniors with macular degeneration, and we've talked about atherosclerosis in PXE. And by and large, we've done many studies, and meta-analysis of studies show that there is no significant increase in cardiovascular complications, fortunately. We talked about the new drug from Novartis where there's inflammation and some vasculitis. So there are risks, which is why we try to give as few injections as possible to get the job done without withholding recklessly, once again.
Thank you. And Wayne, thanks for sticking around. It was like magic. I could just draw you in.
I'm working on tomorrow's talk, and I have this on in the background.
Thank you. Great. All right, Susan, you're up next. Let's see, Susan, can you hear me? I think you're muted.
I am. Yes, I am. Is it me?
No, Susan Ritchie.
Different Susan, fine.
This one will have a North Carolinian accent, perhaps. Can you unmute, Susan? There you go.
I'm afraid you did answer my question. Thank you.
Okay, great. Samantha, and then Sue, if you have a question after Samantha is next.
Hi, can you hear me?
Yes.
This is probably for Dr. Fuchs as well. There's 2 references with regards to issues with the eye, the bleeding, and then he mentions leakage. What is the difference between bleeding and leakage? I've had bleeding in my eyes and several injections over the last couple of years, but I've always heard it referred to as bleeding. What is the difference between bleeding and leakage?
Well, so we talked about these new blood vessels and the fact that they are leaking and can bleed. So blood vessels, generally speaking, are competent. So the vessels underneath the retina in the choroid and choriocapillaris and your small, tiny vessels in your body, your capillaries, they do leak for a good reason. They exchange oxygen.
Now you could ask.
Sorry, I'll mute that person. Go ahead. I muted you. Sorry, Wayne.
All right, so, and that's it. No, I'm teasing. And so these vessels that grow under the retina are abnormal. So the cells in a blood vessel usually are very tight to one another. We call it tight junctions. So these are now have fenestrations or leaky spots. If that leaky spot is very tiny, it's large enough for liquid to seep through. So that would be leakage, clear liquid. The serum, you know, your blood, if you took blood and put it in a test tube, it would settle. Maybe 40% of it would be red blood cells and 60% would be clear liquid or serum. So the leakage we're speaking about is that serum that's leaking out, and there would be clear liquid, and that can cause distortion of vision because it elevates the retina. If the leaky spot in the blood vessel is larger, red blood cells can fit out, and then instead of just liquid, you have, you know, blood. It's not a large hemorrhage, but if it's even 2 millimeters or so, that would be in the wrong spot. That can cause serious damage to the vision. So we're talking about the same vessels that are both leaky and fragile, if you will, but fragility is really just a little bit of larger opening, allowing blood cells to seep through. And so it's the same vessels, and we like to catch them when they're leaking because, as I said, once they bleed, even though that blood does go away eventually, it does leave damage. So we like to catch it before the bleeding stage.
So I'm assuming that my retinal surgeon would be able to see the leakage. He does the OCT scans every 4 weeks. And yeah, okay. Yeah, because he's never referred to it as leakage. So
right. So it's hard to see leakage if it's a tiny bit of clear fluid. The OCT machine usually does not miss that. And the other advantage of the OCT machine is it's quantitative. So if I look in and I see that there is some fluid, I know there's leakage, and I treat, and the patient comes back a month later and there's still a little bit of fluid, it's hard for me to know, was it 350 microns? Is it 375 microns?
Right.
Is it, but the OCT will show if it's more or less and help the patient, help us guide the treatment, reassure the patient that they're looking a little better, there's less fluid. And if there's more fluid, they obviously need another injection.
another shot.
So,
Okay.
but it's very hard to see a tiny drop of clear fluid.
Okay, thank you. I was just interested in the leakage versus the bleeding.
Well, they both fall into the category of what
yeah.
we would call wet or active disease.
Yep. Okay, thank you.
Thank you.
Along those lines, what we've heard from some individuals is that they go to the ophthalmologist saying they see a distortion on the Amsler grid. He says he sees nothing, or she, and then they go back 2 weeks later and it can be seen then. So do you think that's that really tricky bit of a place where maybe the OCT is not picking up the same thing the person is picking up?
Well, we respect the patient's subjective complaint, and that, as I said, we set the bar low. We would strongly consider treatment if they have been very carefully watching the vision and think that there's been a change in the grid. That would come into the equation when we're deciding whether they need an injection or not. It's important to look at the grid on a regular basis because obviously if there are streaks, sometimes the lines can be a little crooked, and so what we ask patients to look for would be a sudden change, a sudden significant change in the grid, and that would usually indicate that something's going on. And I think most patients would be treated if they came in with that symptom.
Great, thank you. I think we're hearing a bit of a wide range of tolerance from ophthalmologists to do that, retinologists to do that. Some don't, and people then move on to the next one. So you're good, thanks. Sue Henning, did you have a question? Okay, Ray Wynn. You're muted, Ray Wynn.
Right, sorry about that. Great. I'm having problems of atrophy in my eye. I lost the central vision in my good eye, my right eye. That was after surgery and chronic constipation, so I lost that. And now I have this atrophy in my remaining eye, which is causing me some problems. How do I prevent atrophy? What do I do to stop that? Can I? What's the problem?
Wayne, that's for you too. Sorry, we're not going to let you write your talk for tomorrow.
Right, I'm going to ask you to tell me about the good eye, and what's the question? How do you stop
Atrophy?
atrophy?
Yeah, that seems to be causing my blind spot in my remaining eye.
Yeah, so we mentioned atrophy. I have just put in a slide about that for tomorrow because I didn't talk about that. Then there was a previous question about that. We don't have a treatment for atrophy. That's one of the things we're working on for the future, you know, with pigment transplants and stem cells, but there is no treatment. When we tell our macular degeneration patients who have a little bit of atrophy to take vitamins and to avoid smoking, that's to prevent the active component, the neovascularization. We're not actually treating the atrophy.
Okay, thanks for that. I'll look forward to tomorrow's lecture.
Thank you. Any more questions?
This is Miriam, and I have one more question for Dr. Fuchs.
Mm.
You had mentioned earlier drusen, and I wanted to know if you would tell us what drusen is.
I don't remember when I mentioned drusen. I mentioned it probably when I was describing the peau d'orange, but drusen are little bumps underneath the pigment layer. And we see that in early age-related macular degeneration of the dry type. And we know that puts patients at risk. It's an accumulation of debris. As the photoreceptors shed the rods and cones, those elements go through the pigment epithelium, through Bruch's membrane, into the choroid, and things are regenerated in the body. And this is really collecting on top of Bruch's membrane, which is an abnormality. So if we examine somebody's eye and we see little yellow bumps, those are drusen, and they look very much like the peau d'orange.
Okay, thank you. And I had one other question. I'm wondering if you could comment on the similarities and differences between age-related macular degeneration and the kind of macular dysfunction that we see in PXE. From the patient's point of view.
It's very similar. The complication of PXE that we don't like to see would be the neovascularization. The angioid streaks, all the other findings that we describe, and when I give a talk to ophthalmologists, I talk more about all the other findings that we didn't mention because like calcified drusen and salmon spots and optic nerve drusen, and none of those are really important. The important one is angioid streaks because they are cracks in Bruch's membrane and they allow blood vessels to grow through from the choroid to underneath the retina where they can leak and bleed, and we need to treat them. In macular degeneration, it's the same thing. We don't worry about these findings like drusen. We do worry about atrophy, but we don't have a treatment for that, so we're looking for one. But the pathology that worries us is similar. It's when neovascularization occurs, and it's not through these large cracks in Bruch's membrane, but it's certainly through microscopic breaks in Bruch's membrane. That's the only way the vessels can get from under the retina, from under the Bruch's membrane to underneath the retina. And we break it down into different areas, whether it's type 1, type 2, type 3 neovascularization, but it's the same thing. It's blood vessels that are abnormal. They leak and they bleed, and we treat them with the same drugs. So fortunately, we can extrapolate from our studies about different pharmacologic agents, and we use them in PXE patients that have similar pathology.
So is it from a strictly experiential perspective, if are macular degeneration patients are likely to experience the same sort of central vision loss as someone with PXE vision loss? I understand that there might be different reasons, you know, from a medical point of view why this is occurring. But is my experience of this going to be similar to someone who has age-related macular degeneration?
I would say it's exactly the same.
Okay. Okay, very interesting. Thank you.
You're welcome.
Thanks, Wayne. Lydia, did you have a question? Okay. Cheryl, can you speak yet?
Can you hear me?
Yes.
Ah, I don't know what it was.
Great.
I was just wondering, this is going back earlier when you were talking about the dentist. I had a dentist and a doctor both refer to PXE as a white person sickle cell anemia. Is that because they have the same symptoms as us, or?
No, that's a very odd statement. The only tie-in I could see is that some people with sickle cell, and they could be white or black. Sickle cell is not, you don't have white people's sickle cell and black people's sickle cell, you have sickle cell. And the only thing they share in common is some people with sickle cell disease have angioid streaks. And Wayne might want to comment on that. That's from literature. And I actually have not heard anything about that in years and years and years, that beta thalassemia, sickle cell, and I can't remember what else might have angioid streaks. And that would be the only overlapping symptom that I would know about.
He says it was my gums that looked like a person who had sickle cell.
Okay. Well, that I don't know about.
Okay.
Well, I agree with Sharon that they both can have angioid streak sickle cell. I've had 3 patients who've had neovascularization in both eyes from sickle cell, and it could be sickle thalassemia, SC disease, but the other thing that sickle cell patients can get is a neovascularization of the peripheral retina and bleeding into the vitreous jelly, and that's more similar to diabetic retinopathy. It's not like PXE patients. So sickle cell is a serious disease of the retina, and but they do get angioid streaks, and we treat them the same way.
And wait, while you're there, cataract surgery.
So we have, that is a common problem in our age-related population. And we feel that, so the questions about whether cataract surgery, number 1, causes neovascularization, and we think it does not from our prospective studies. And the other question is cataract surgery safe in someone that has had neovascularization and has had injections? And the answer is yes, but if someone has had injections or needed them in the recent past, the last few months, they're not stable, maybe they didn't have a shot for 2-3 months, but they're thinking of cataract surgery, most retina doctors will give an injection 1 or 2 weeks before surgery just to protect the eye, because even though cataract surgery is done these days through a small incision, they don't even need a stitch. There is some inflammation involved. That's how the eye heals. And inflammation's implicated in many diseases like neovascularization. So we like to have the anti-VEGF on board for the patient. That's not carved in stone. There's been no prospective study. That's just how most people are practicing these days. And then the other issue is we should always warn patients who have macular disease that the benefit of cataract surgery will be limited by their macular disease. You know, the chain is as weak as the weakest link. So yes, you'll get rid of the cataract component of the decreased vision, but they still will have macular pathology that may limit the benefit of the surgery. And it's very important to explain that beforehand so you don't have a disappointed patient who, let's say, gets a couple of lines better on the eye chart, but they were expecting 20/20 vision like the neighbor down the block. They just need to know that if there's another comorbidity, another disease, that will limit the benefit.
Great. Thank you, Wayne. We're going to move now, we're over time, into the next section, which is a section on support. And initially it said that you would have a PXE staff person in every room. We did not expect such a large turnout, and so you will not have a PXE staff person in your room. So I just want to give you a couple of pointers for when you're in your rooms. This is a time to do networking, to talk about support. So you will be in a room with other people who are experiencing either PXE themselves or with their loved one. And what we would like for you to do is to feel free to share with one another about how you're coping and what you're doing. But I do want to say, do refrain from any advice to each other. Everybody's lived experience counts. We're really wanting to validate everybody's experience so people know that their experience is just as valid as someone else. Their way of coping is just as valid. I love sort of looking at how each of us really needs to bow to our defenses in a lot of ways. They keep us sane and alive and well and so on. And so we really want you to hear each other, but not to give each other advice. So no interpretation, no analysis, no advice. Nobody's a counselor of somebody else, essentially. So giving each other a lot of space. I'm going to open the breakout rooms. You're going to have until 15 after the hour, so a little less than an hour. We had hoped for an hour. And then we'll come back together for closing this session. Okay, any questions before we go on that logistical piece? All right, I'm going to open the rooms now.